all my teachers, seniors, and Dr. Roy sir, mute. Kindly requesting kindly to unmute.
Hope I am audible now.
Yes, sir.
This actually neonatal sepsis and this meningitis were one of the things which we find it difficult to manage previously and now also. Meningitis, of course, in older children, it is in second half of infancy and older children, it is coming down because of the active vaccination, especially the hib vaccine and pneumococcal vaccine. But neonatal sepsis is still there, and in some cases there will be associated meningitis also. And the diagnosis and the management itself is very difficult, and how many days the antibiotics have to be continued and whether they are actually really needed. And it's a tricky situation, especially when the IV lines are very difficult to get and maintain. And that is so much of expertise, especially not only the neonatologists, the nurses also have to be trained like that. So the significance of this today's journal is for that. Hope we will get some insights after this. Over to our PGs.
Thank you, sir. Dr. Maya Menon, can we go to the presentation?
Yes, definitely.
Okay, now I'd like to request Dr. Anisha Robinson to present the article.
Good evening, everyone. Am I audible?
Yes, sir. Yes, madam. Okay.
Good evening, everyone. I am Dr. Anisha Robinson, first year postgraduate from SUT Vatapara. So I am presenting an article from Indian Journal of Pediatrics on 10-day versus 14-day antibiotic therapy in culture-proven neonatal sepsis. It was an RCT, randomized control trial, done by Asha, Reddy, and HR in the Department of Pediatrics, Indira Gandhi Institute of Child Health, Bangalore. So background of the study is neonatal sepsis is one of the most common causes of neonatal mortality all over the world. Most of the sepsis-related deaths are due to multi-drug-resistant organisms, which is due to rational and prolonged use of antibiotics, which in turn changes the normal microbiome, prolonged hospital stay, and thereby increases the incidence of nosocomial infections, increases the risk for secondary bacterial infections and fungal infections. This in turn increases financial burden and wastage of human resources. So basically the objective of the study was to compare the efficacy of 10-day versus 14-day antibiotic therapy in neonates with culture-positive sepsis. So primary outcome of the study was treatment failure within 14 weeks of discharge. That means treatment failure was defined as readmission to the NICU within 4 weeks of discharge with blood culture growing same organism with similar antivibram, or any readmission with signs and symptoms of sepsis with negative blood culture. And secondary outcome would be duration of hospital stay and mortality. The methodology was studies design was a randomized controlled trial. Study period was between April 2018 and September 2019, which in turn was a total of 1 year and 6 months study. It was done at a level 3 neonatal unit of a tertiary care center. Then study population, all the neonates who presented with signs and symptoms of sepsis with culture positive were assessed for as eligibility. It includes the inclusion criteria were gestation age more than 32 weeks and or birth weight more than 1.5 kg, neonates with positive blood culture who had received 7 days of antibiotics, no clinical signs of sepsis, on day 7 and sterile blood culture, the negative sepsis screen on day 7 of antibiotics. And exclusion criteria was neonates with any major congenital malformations, any deep-seated infections like meningitis and septic arthritis, fungal sepsis, staph aureus sepsis, and severe birth asphyxia. Then sampling procedure, all eligible neonates who met all the inclusion criteria and none of the exclusion criteria was randomized at the end of 10th day of antibiotics. Neonates in the 10-day group received no further antibiotics, and neonate in the 14-day group received antibiotics for more than 4 more days, that is a total of 14 days. Method of data collection was clinical, demographic, and baseline data was collected in neonates and recorded in a pre-designed performer, which included complete blood count, then CRP, which was found to be significant more than 10 milligram per liter, blood culture, micro ESR, peripheral smear, antibiotic susceptibility testing, peripheral venous sampling. And follow-up. In both groups, neonates were observed for 48 hours in the hospital for any clinical signs of sepsis. After that, the neonates were followed up telephonically on a weekly basis for first 3 weeks, and then they were called up to the hospital at the end of 4th week. And parents were also instructed to call the chief investigator if any clinical signs were seen within the 4 weeks of discharge. So a total of 122 neonates were assessed for the eligibility during the study period, out of which only 70 had met our inclusion criteria, and exclusion criteria was excluded. And out of this 70, 35 neonates were randomized into 10-day group, and other 35 were randomized to 14-day group. And this is a process. First, it was allocated. First, it was allocated, that is, out of 35 out of 70 neonates, 35 were allocated to 10-day group, and other 35 were allocated to 14-day group. Then follow-up was also done. After that, we analyzed the results. The results, according to the study, was the first one, the type of organisms. According to their study, 90% accounted for gram-negative sepsis. That too included mostly in 14-day group. Then the clinical, demographic, and laboratory characteristics, the neonates were actually compared based on different parameters, which include the sex of the baby, the birth weight, gestational weights, any risk factors for sepsis, and which can again be divided into early and neonatal sepsis. Then clinical features, in which the most common was respiratory distress. Then other features were poor feeding, poor cry, hypotonia, shock, hypothermia, or hypo or hyperglycemia, and need for ventilation. And laboratory features which were considered was total leukocyte count, ANC, CRP, and platelet counts. The next one was the bacterial profile, out of which the Klebsiella was the most common one, which was found to be positive. And coming to outcome, the treatment failure was seen only in 1, loss of follow-up was seen only in 1, and mean duration was actually almost same, and death was 0. This was according to the table. In short, Klebsiella species was the most common organism seen, which was almost around 51% of the babies, followed by Acinetobacter, which was 15.71%, followed by E. coli, which was 11.42%. And among the gram-positive bacteria, Coagulus negative Staphylococci was most common one. And there was 1 treatment failure in 10-day group and 1 readmission among the 12-day group. And mean duration of the hospital stay was significantly lower in 10-day group as compared to 14-day group. And there was only 1 loss of follow-up in each group. Coming to the discussion part, this is a RCT, and it was a pilot study, and it was found that 10-day antibiotic therapy is feasible in neonates with culture-positive sepsis. As per the study, most of the infections were gram-positive organisms. Since the other center is an exclusive outbound unit, the incidence of late-onset sepsis was more common. And as they included only nearly stable babies who were randomized after 10 days of antibiotics after achieving clinical remission, these neonates would have probably cleared off bacteria from their blood, and additional days of antibiotics would have not been beneficial. And there was no difference in primary outcome, that is treatment failure between the 2 groups. That may be due to inclusion of more mature babies in the study. And mean duration of hospital stay was also significantly less in 10-day group without any increase in failure rate. Coming to the limitations of the study, the sample size was small and it was not mentioned what kind of sample formula was used for choosing the number of sample. Then having included the neonates with Staph aureus sepsis, which is one of the most common causes for gram-positive infections, and haven't included any deep-seated infections, and they have included only relatively stable babies. So in turn, the conclusion was, according to their study, 10-day antibiotic course is as effective as 14-day course in neonates with culture-positive sepsis. That's all from my side. Thank you. And now, Dr. Keerthana Krishnan will proceed for the analysis of the study.
Over to Dr. Keerthana.
Good evening, everyone. I'm Dr. Keerthana Krishnan, first-year postgraduate student from Department of Pediatrics, SUT Academy of Medical Science, Vattapara. I'll be analyzing the journal article which is presented by Dr. Anisha Robinson. So, randomized control trial. Randomized control trial is one of the most powerful, most reliable tools of clinical research. They are prospective studies used to measure the effectiveness of a new intervention or treatment. Consort. What is a critical appraisal of a journal article? It is a systematic process used to identify the strength and weakness of a research article in order to assess the usefulness and validity of research findings. Consolidated standards of reporting trials, that is consort, was created to ensure high-quality presentation of the conducted RCT. These guidelines consist of 25 checklist items that the author has to fulfill before submitting the manuscript to a journal. So these are the consort 2010 checklist items. It includes 25 checklist items. So coming to our journal article, in the consort, the first checklist is title and abstract. 1A is identification as a randomized trial in the title. It is actually given in our journal article. In the title included RCT, that is 10 versus 14 days of antibiotic therapy in culture-proven neonatal sepsis, a randomized control trial. 1B, structured summary of the trial design, methods, results, and conclusions are given in the abstract. As you can see, it is given in the abstract of the journal article. Then coming to the next checklist, it is background and objectives. In 2 ways, scientific background and explanation of rationale. The scientific background and explanation of rationale, including the etiology of neonatal sepsis, development of multi-drug resistance, and because of the prolonged use of antibiotics due to longer duration of treatment, and the risk of secondary infections, change in microbiome were discussed in our journal article. It is also mentioned that there are only few studies that have evaluated the shorter course of antibiotic regimens with varying results. 2B, specific objectives and hypothesis. There was no hypothesis mentioned in our study, but specific objectives were clearly mentioned in our study. The primary objective of the study was to compare the 10-day of IV antibiotics with 14-day in neonates with culture-positive sepsis. Duration of hospital stay and mortality were considered as a secondary outcomes in this article. In the checklist, next comes the trial designs. 3A, description of trial design, including the allocation ratio. So they have mentioned that it was a pilot RCT, including 70 neonates who presented with signs and symptoms of sepsis with positive blood culture. And these neonates were recruited for the study. The allocation ratio was 50:50. This was clearly mentioned in the study. 3B, important changes to methods after the trial commencement. In our study, there was no changes after the trial commencement. Then in the checklist, next comes the participants. In 4A, eligibility criteria for participants. In our study, the eligibility criteria, in both inclusion criteria and exclusion criteria are clearly mentioned in our article. 4B, settings and locations where the data was collected. It is also mentioned that the study was conducted between April 2018 and September 2019 in level 3 NICU of a tertiary care pediatric hospital in South India. In the checklist, next comes the interventions. 5. The interventions for each group with details such as how and when they were actually administered. In our article, they have mentioned that the neonates were selected according like that. At the 7th day of antibiotics, in the inclusion criteria, it was mentioned that at the 7th day of antibiotics, after the 7 days of antibiotics, they will do the sepsis screen and blood culture, and those neonates who are negative with negative sepsis screen and blood culture negative were randomized for the study. So they have mentioned about all these details. Next heading in the consort checklist is outcomes. 6A completely defined the primary and secondary outcome measures and how and when they were assessed. In our journal article, they have mentioned the secondary and primary outcomes. The primary outcome was their treatment failure, and secondary outcomes were the duration of hospital stay and the mortality. 6B, any changes to trial outcomes after the trial commenced. There were no changes to trial outcomes after the trial was commenced. The next heading in the checklist is sample size. 7A, how sample size was determined. Even though they have not mentioned the equation for calculating the sample size, they have mentioned that since being a pilot study, they have selected a sample of 16 neonates, and assuming a loss to follow-up rate of 50%, they recruited 70 neonates into the study. And 7B, when applicable, explanation of any interim analysis and stopping guidelines. Actually, there was no interim analysis or stopping guidelines mentioned in the article. Next heading in the consort checklist is randomization. 8A, methods used to generate the random allocation sequence. They have mentioned that randomization sequence was generated and treatment assigns were placed in identical serially numbered opaque and sealed envelopes to ensure allocation concealment. So they have mentioned how they generated the random allocation sequence. 8B, types of randomization, details of any restrictions such as blocking and block size. They have not mentioned which is a type of randomization, and they are not mentioned about the blocking or block size. Next comes the allocation concealment. 9. Mechanism used to implement the random allocation sequence, the detailing any steps taken to conceal the sequence until interventions were assigned. So they have mentioned that after generating the randomization sequence, the assignments were placed in identical serially numbered opaque and sealed envelopes to ensure allocation concealment. Next comes the implementation. 10. Who generated the random allocation sequence, who enrolled the participants, and who assigned the participant to intervention. This was not given in the journal article. Blinding. 11A, if done, who was blinded after the assignment to intervention and how? There was no blinding in the study as mentioned in the article. Statistical methods. 12A, statistical methods used to compare the groups for primary and secondary outcomes. Actually, they have mentioned that the mean was used for continuous variables. The pair data was analyzed using student t-test and proportions were analyzed using chi-square test, and the data entry and analysis was done using SPSS version 18. So they have clearly mentioned about the statistical methods. 12B, methods of additional analysis such as subgroup analysis and adjusted analysis. There was no subgroup analysis or adjusted analysis in the study. Results, participant flow diagram, it was given in the article. 13A, for each group, number of participants who were randomly assigned, received intended treatment, and who were analyzed for outcome. 13B, for each group, losses and exclusions after randomization together with reasons. Actually, they have discussed very clearly in this participant flow diagram that they have assessed 122 neonates, and they have excluded around 57 neonates and randomized 70 neonates. The allocation ratio was 50:50. They allocated into 35-35 two groups, and the further steps were followed accordingly. Next comes the recruitment and baseline data. 14A, dates defining the periods of recruitment. Actually, they have given it was between April 2018 and September 2019. 14B, why the trial was ended or stopped. Actually, the trial was not ended abruptly. It was stopped by itself. 15A, table showing baseline demographic and clinical characteristic of each group. It was also given in our article. 16, for each group, number of participants, that is included in each analysis and whether the analysis was by original assigned groups. This was also mentioned in the participant flow diagram. Next heading in the checklist is outcomes and estimation. 17A, for each primary and secondary outcome, results of each and the estimated effect size and its precision size. They have mentioned, they've calculated the treatment failure, loss to follow-up, and the duration of hospital stay, and they have calculated the p-value for the outcomes. 17B, for binary outcomes, presentation of both absolute and relative effect sizes recommended. Actually, in our study, there are no binary outcomes. Ancillary analysis. 18, result of any other analysis performed, including subgroup analysis and adjusted analysis, distinguishing pre-specified from exploratory. There was no specific analysis done in this study. Harms. 19, all important harms or unintended effects in each group. There were no harms or unintended effects mentioned in the study. Coming to the discussion, 20, limitations. Actually, they have clearly mentioned the limitations of their study. The limitations included their sample size was small, they included relatively stable neonates, and they excluded staph aureus sepsis. So all these were limitations of their study, they were mentioned. Generalizability, 21, generalizability. Actually, they have said in their article that the findings of the present study cannot be generalized because they have not included the staph aureus sepsis, which is one of the most common cause of sepsis, and also due to the lesser sample size. 22, interpretation consistent with results, balancing benefits, harms, and considering other relevant evidence. They have clearly mentioned their results and they have interpreted correctly, and also they have included other relevant studies, which including Rohataki, the study was related to the antibiotic course, 7-day versus 10-day course of antibiotics in neonatal sepsis. So they have mentioned about all those details. And other information, 23, registration number and name of trial registry. It was not available in the study. 24, where the protocol can be assessed. That was also not given in the article. 25, funding. There was no funding agencies mentioned in the study. So coming to the consort checklist, out of the 25 checklist, about 19 were satisfied by the study. So actually, according to the consort checklist, it's actually a good study. Thank you, sir.
Okay. Thank you for that excellent presentation as well as the detailed analysis. Now we would like to hear from Dr. Ramankutty sir regarding the expert analysis. So I would request Dr. Ramankutty sir to give his.
Oh, okay. Thanks for the presentations. The residents who presented as well as analyzed the paper according to the consort guidelines, they did a very good job. But adding my personal opinion, I can't agree that this is a good study, and I will explain why. Even though you have 19 out of 25, to me it actually tells me that the checklist, actually you can tick all the boxes in the checklist and then even then end up with a bad study. So the one question I want to ask is, what is the take-home message? Will you really reduce your antibiotic? I don't know what is the current practice. That is the number one issue. So I may be saying some nonsense, so please bear with me. But if the current practice is 14 days, would you change to 10 days based on this trial alone? I don't think so, because it ends up in a non-committal way saying that, there is no significant result. So you are left to your own imagination, and they say that you have to continue and do another study. So for an RCT, that's not a very good conclusion. The problems with this study are two, I would say. One is the ethical issue, which I want to mention, and that's why I'm saying I'm not an expert, so I don't know. Is there a real question here? If people want to reduce the duration to 10 days, was it justified? Subjecting children to the study, was it justified? Obviously, the the ethics committee has passed it, so which we have to assume that they have some rationale. So I can accept that. But the more important technical issue for me is the statistical issue, which is the very poor sample size. So if you really want to discriminate, you can't do it with 35 and 35. I did a rough calculation, and the power comes to about less than 20% or so, which is very, very poor. We need usually about 80% power to report a good study. Of course, they claim that this is a pilot study, which is fine. So pilot study is just to establish that it is feasible. In that sense, maybe it is justified. So which means you have to do a further study with adequate sample size. And according to my calculation, the adequate sample size, based on certain assumptions, which may not be correct assumptions, but it will be like at least 200 babies in each arm. So of course, I'm assuming some other calculation, so may be wrong. So that is how it is. So it raises a question of negative results. That is, whenever you are reporting something negative, that there is no effect, then the power becomes important. When you are reporting something positive, you don't bother much about the power. But when you are reporting something negative, unless it is an adequately powered study, then that study is of no use. So that is an important message from this paper, I think. And one or two corrections. Somebody who looked at the checklist said that it is not a binary outcome. It is a binary outcome. What is a binary outcome? Binary outcome is a yes/no outcome. Here it is infection, yes or no, right? So it is a binary outcome. Okay. So it is actually a binary outcome that they're looking at, and that is one thing I wanted to point out. And there is some other thing which I had in mind, but I am not remembering now. Something in the study itself which they have mentioned. That is a checklist they have mentioned that it has not been. Of course, there can be no blinding in this because one is 10 days, other is 14 days. It's obvious that one is longer than the other. So you cannot obviously blind at least the treating people, or even the patient cannot be blinded because of this particular issue. So that is one weakness which cannot be avoided because it is a research question is of type. You are looking at two interventions, so you cannot blind that. So these are some of the issues. The other thing which if I remember, I will bring it up again. So.
Good evening, Dr. Josar, and I would like to request Dr. Josar, who is a teaching faculty at IAP also, to give his comments as his wishes. Or Dr. Josar. Good evening, sir.
Dr. Anju, is audible? I am audible.
Yes, sir. Yes, sir.
So, respected Ramankutty sir, Ramankutty sir and Dr. Beno and Dr. Roy sir and other SR from SUT. I think I congratulate SR. They have taken all initiative to present the Jana Club because the Jana Club is very important for our academic activities concerned. So that Vandam is doing a wonderful job. I'm happy to hear the words from Ramankutty sir because that is why I'm joining here. So always his comment on Jana Club is very, very informative, and regarding critical analyzing is very important in Jana Club. So we will get a lot of publication regarding different studies regarding 5 days, 10 days versus 14 days. Different study will be there. Whether it is whether it can be, as Ramankutty sir mentioned, whether it can be practical, we can practically implement it. The issue is a concern regarding the study strength regarding the factors. So I think as sir is mentioned, because this is a lot of this is taken as a pilot study, so we need a lot of the sample size is very minimum, so that we cannot implement it to the generalization regarding the duration of antibiotics in especially in the newborn is concerned. So I think that the criticism that is very important, and I think that this program will be the how do we analyze a journal club is very important. As a undergraduate students is concerned, analyzing a issue of a journal club is very important aspect of their academic activity. So the congratulations to the CTJR and all of you regarding this wonderful program, and wish you all the best. Beno, I congratulate Beno for all these things. Okay. Over to Anju for further.
Joe sir, we have Dr. Roy Shankar sir, who is a HOD of SUT Academy of Medical Sciences with us. Dr. Ravishankar sir, Dr.
Hello,
Joseph.
good evening. Actually, I heard everything, and this kind of study was conducted in Indira Gandhi Hospital. Actually, they are having a very good ICU setup, and the number of patients are also very high. So they should have taken a little more number of patients, maybe some 50 or 75 like that. Not from a small center. I think it's, they are having the maximum number of ICU beds.
The ICH Bangalore having ICU bed strength of I think more than 75 in the ICU, and they are flooded with the patients in Bangalore Government Medical.
They are getting reference from all over the maybe some 100
big institute.
radius.
It's a big institute. I think three or four ICU for OBN also. The big size.
So they should have taken more sample size and get an inference. But still, I feel actually we are giving antibiotics a little more because we are afraid. So many illnesses we were giving antibiotics, say for pneumonias and all. We were previously giving some 14 days. Now we have cut short it to 5 days, 7 days like that. And the antibiotics also used are also not crystalline penicillin and all, which we were practicing some 30 or 40 years back. So broader spectrum antibiotics, and they are having better effect, and the side effects are also more. So it's a welcome study, I must say. We should also, for other illnesses, we should cut short the number of days.
Thank you, Ravishankar sir.
And one more point, actually.
Dr. Ben. Sir, please, sir.
One more. Actually, this I still remember a study in Indian Pediatrics somewhere in 2003 about the CRP, role of CRP in neonatal sepsis. So much of importance is given to CRP. Everybody, for all illnesses, we are asking for CRP. Is it that helpful? I think we don't have that many investigations, but at least this study in Indira Gandhi Hospital, they were stressing upon the blood culture, and CRP was not given that much importance. But for neonatal sepsis and other sepsis in older children and any illness, people think that CRP positive is acute phase reactance positive is a license to start antibiotics. And neonatologists are asked, what is your opinion and all? Is it that
Dr. Benno,
but we don't have anything else. We are
also
asking for
Secretary IAP TVM to give his comments on this as well.
Thank you, sir. Thank you, Anju sir. Thank you, Ravishankar sir. And as Ravishankar sir was telling that, was suggesting about the use of CRP. So, sir, what we generally do is, of course, both are important. That is CRP.
Not prognostic wise, definitely it is significant. Prognostic.
Yes, sir. So what I would say is, sir, apart from CRP, definitely you need a CRP and you need a blood culture. Apart from that, most importantly, you go for your clinical assessment. The baby you think the baby is sick or the baby is in the verge of developing sepsis, definitely test can start with that. And it's actually getting better. Then I don't think there is a point of continuing for like 5 to 10 days. I think as Ravishankar said that previously they used to practice continuing antibiotics for maybe 10 or 15 days. Probably you can continue of the antibiotic administration. Probably you can give it for maybe 3 to 5 days, and then you can.
Yeah, can I just say something?
Please, sir. Please.
Just remembered what I was that I had noticed, and about the endpoint, they have said that I mean, there's no satisfactory reasoning for why they ended that study. Like, of course, I can imagine if they have a rationale for the sample size, saying that this is an adequate sample size, we have done the power calculation, then we are doing this. But they didn't do that. They just had 70 patients randomized and then suddenly stopped. So that is also, I think, it's a weakness of the study. At least the way they have written up, they could have explained why. Maybe they considered it as a pilot study and they just wanted to do 35. That is fine. But then, of course, as I said earlier, then that is not very helpful in the long run. They have to do another study to address the same issue.
Sir, in areas where there are no studies done earlier, is it not very difficult to calculate the sample size in a pilot study?
That is right, but there is another approach in clinical trials which is called a sequential approach, which means that you calculate the power and all, but you may not get, so you go on doing this, you go on randomizing patients, and then you can back calculate, whether what is the effect that we have found. And at that point where you think it is convincing, you can stop. That is another new approach in clinical trials. You don't go with a pre-assumed sample size, but then you start randomizing. Maybe when you reach 50-50 or whatever number, then you suddenly find that there is a good difference, and then you are convinced that it is effective, and then you stop. So you have to set down your criteria before you start the study. Here, I don't think that has happened, because finally when they stop, there is only one difference of one event, isn't it? The difference between the two groups is
actually the number of patients who got readmitted was equal, which is equal to 1 in both the categories.
Yeah, that's right. There is absolutely no difference. So, as somebody mentioned, in such a large hospital like this, they could have continued the study for some more time, and then look for any difference emerging from, So that was not done. I don't know why. Because I accept. I mean, I can understand that maybe practical problems like, they didn't want to subject too many people to this study or whatever. People are not consenting. I don't know what is the reason. So there is some kind of a gray area in that area. That is what I want to mention. Just one point before that, now that you have mentioned ethics committee, that is also another doubt I had, because they say that it is not registered. Now, my experience, I'm sitting in several ethics committees. Any clinical trial, whether it's a pharma supported trial or an academic trial, any current modern ethics committee insists that you have to have a register number. Without that, they don't allow the trial to go forward.
Then it is
obvious. In that sense, also it is doubtful. Yeah.
Yes, sir. Over to Dr. Maya.
Thank you, Dr. Anju. Actually, good evening, Ramankutty sir, and all IAP parents here. And thank you. First of all, let me thank IAP Trivandrum for giving our postgraduates the opportunity to present the journal before a veteran like Ramankutty sir. And in fact, I should give a special thanks to Anju Kanmani, who motivated us to do this presentation. And actually, sir, we know that the study has limitations and it's a pilot study. In fact, we have selected this because actually in neonatal sepsis, actually protocols differ, sir. Actually, even textbook of Cloharty, textbook of Nelson, they say that we can give antibiotics for blood culture positive newborns for 10 to 14 days. They are mentioning like that, 10 to 14 days like that. And they have not mentioned 10 days or 14 days like that. And for meningitis, it is 21 days they have mentioned. Maybe Dr. Benno, if he's here, he can enlighten us further regarding that. And nowadays, what is the problem is that patients refuse to stay back in the hospital for around 2 weeks for continuation of antibiotics. Everybody wants to go home fast. And moreover, like once the baby becomes better, they refuse to stay back. That is one reason, sir. And moreover, there is more like demanding for the healthcare personnel, and then nosocomial infections, difficult IV cannulation, secondary infection, all practical problems are there, like if you prolong the hospital stay. So there are many other studies also they have done comparing like whether 7 days possible, 10 days possible, or 14 days are possible. I think they have just tried to, assess whether 10 days is enough for a blood culture positive sepsis, just to cut short the duration of hospital stay. But they have not, their sample size is very less because they have excluded severe sepsis like staphylococcal sepsis and serious neonates who are seriously sick were excluded. Even though it is a large center, they have not, maybe due to ethical reasons, they have excluded the seriously ill neonates. That is one one reason. And they have pointed out their limitation also. They said that there is poor external validity because they have excluded the seriously sick neonates and especially the staphylococcal ones and the very low birth weight babies, extreme preterms that they have excluded. So they have suggested to do a larger trial that they have done. That is why we have chosen this study, just to know whether is it feasible to cut short the duration of treatment. If Dr. Benno is there, I think he can enlighten us regarding how long a blood culture positive baby need to be given antibiotics. 10 days or 14 days is a must, like that. And as Sir pointed out, there is no registry. The number is not there. And now Sir has said it's a must for even pilot study to have the number. And even sample calculation is a must for pilot study also, no, Sir?
Yes.
Anyway, we are very happy to have presented to you, Sir. Thank you, IAP.
I think, as I told you, the presentation was excellent, and I'm not even talking about the choice of the paper, because the paper is very well written and it's structured and all that. So I'm only talking about the technicalities, including the statistics. So
okay, sir. They have admitted.
Yes, to discuss. You know, if you discuss a perfect paper, there's nothing much to discuss.
Yes,
So,
exactly.
Okay,
Sir.
a lot to discuss.
Okay, I think they have done justice to their presentation. Okay, and thanks you, sir, and Anju, Kanmani, doctor, for the help you have said. Okay.
Okay, thank you, Maya, doctor. Another thing is that this GBS was also not found in any of the cases also. That was another interesting.
Actually, they say that in India, actually, it's more of gram-negative sepsis. In early onset and late onset sepsis, it is more of gram-negative sepsis, including Acinetobacter, E. coli, and Klebsiella. GBS is not very common there. Again, Dr. Bedno, if he is there, can enlighten us more on that.
Bedno was
But
there,
it's
but
more of gram-negative sepsis.
Conspicuously absent, actually. Dr. Srijyoti?
I have nothing more to say. Actually, as Dr. Maya told, we got a great opportunity to present before Ramankutty sir, and it was also with great inspiration by Dr. Anju. Dr. Anju has persisted us to present this case.
Okay.
Actually, we selected this case because we know that there are a lot of faults, limitations in this study, but actually we thought that it will be a great journal to present, so that we can learn more about how can we present the journal and how to analyze. In fact, it is, for me, it was a first experience, and actually I did not know how to analyze a journal and all things. But we did it because of the persistence from Dr. Anju, and we are very grateful to Ramankutty sir to address the journal club and to present before you, sir. And actually all other things, all my other pioneers in this field had discussed. And neonatal sepsis, in all recommendations was if we had to continue for 10 to 14 days. Even we have a dilemma, even a positive culture, previously positive sepsis, whether to continue. We can stop after 10 days or 14 days when the baby is clinically better and his sepsis screen is negative. So, but we can, even the study itself, they're saying that we cannot generalize to we cannot extrapolate it to the general population.
Yes. Exactly.
For discussion, I think, as sir said, it was a good journal.
Yes. Thank you, Dr. Sri. Dr. Karthik. Madam, do you have any comments, madam?
No, I actually don't have much to add. When experts like Ramankutty sir and Roy sir are there, I don't have much to say about it, because statistics, I am not proficient in that field also. But a great thanks to IAP, because this is our first batch of postgraduates. Keerthana and Anisha are our first batch of postgraduates in our college, and it is such a great opportunity for them that they could present a journal club during their first year itself to a maestro like Ramankutty sir, and could hear his valuable comments. They can improve themselves such a lot. Years back, we have only when we presented a journal club, it was years back during our PG days. So this was a great experience for us also for all the three of us. And the only thing I had a doubt was about the study was sepsis and early onset. But the number of late onset sepsis cases were high, and this was specifically done in an outborn unit. So can we generalize this thing to newborn sepsis as such? Because in a late onset sepsis in an outborn clinic, the kind of organisms we usually find will be different from the early onset sepsis. And most of the patients might have gone home and come back. So the organisms may also be different. Can we generalize that to neonatal sepsis as a whole when there is something like early onset sepsis and late onset sepsis? And when this is done in an outborn unit, not in a, it's not a combined study of the inborn and the outborn units. This was specifically done in an outborn unit. So can we generalize this to a treatment guideline as a treatment guideline for neonatal sepsis?
Exactly, that's a very good point.
That was the only yes, and I was asking sir whether it is possible to generalize, because this was done in an outborn unit.
From a technical point of view, that is what I also said, because it doesn't give a convincing message either way. So actually you can't follow any guideline from this, because you have to do further studies. That is what they have said. So a clinical trial should not give such a message. It actually should put one way or the other. I think that is the weakness of the study. Of course, they have always they have been defensive, saying it's only pilot. Pilot. They have demonstrated that it is feasible to do a study and it may be worthwhile doing the study. So that's all they have done. Actually, if you want to answer that question, you need to do further studies.
Thank you, sir. No, thank you so much. And thank you, Anju and Beno sir, for this opportunity for our students. Thank you so much, Ramankutty sir. It was a great pleasure listening to you. Thank you, sir.
We had a doubt regarding like 10-day. Most of the protocols say 10 to 14-day antibiotics for blood culture positive newborn sepsis. So what are your comments as a neonatologist? Because mostly, usually what happens is that the mother is usually discharged and the baby has to stay back for quite a long time. So in the study also, they were comparing 10-day versus 14-day. So, now it was only a pilot study. They have suggested more studies. So what is your valuable comments?
Madam, if you would ask me, I would early go as per clinical assessment. And even I have given a child 21 days of antibiotics who actually had developed clear-cut meningitis. Child was around, I think he came at 21 days of life with poor activity and poor feeding. So when we saw that CRP was positive and his CSF was clear-cut meningitis, so I had to give him a dose of 21 days of antibiotics. That is there. But as Maya ma'am had said that giving 14 days of antibiotics and cost becomes an issue and parents also gets discharged. Madam, I would say that you would...
IV cannulation.
Cannulation is a difficulty that we do face in our NICU. So ma'am, I would say that go by clinical assessment. Rather than doing CRPs and going as per your stringent guidelines, I would say go for 5 to 7 days of antibiotic course. And you think the child is actually becoming better, then probably you can plan for a discharge. Rather than waiting for 14 days.
Positive, 10 days,
no, 10 days. No, if you're asking me, I would go for at least 10 days of antibiotics.
Blood culture positive.
Okay. And if it's meningitis, if it's clear-cut meningitis, definitely I will go for 21 days of antibiotics.
Okay, thank you.
Cannula is an issue, madam. Cannula is an issue.
Yeah, do we have any positive blood pressures from these long lines system? In your experience,
long lines,
21 days.
Sir, I think this child which I had actually treated, repeat culture actually was negative. Maybe after we had taken a repeat culture, probably after 10 days of giving antibiotics administration. Yeah. So it was actually after that, since it was meningitis, since it was clear-cut meningitis, we had to continue still for 21 days. But actually counts in the parents previously itself that we'll have to do an LP, and if it turns out to be a positive, then we'll have to continue for 21 days. And thankfully, the parents were actually well off.
Yes.
Mhm.
yes.
So
That is
Yeah.
another problem. Cost
Yeah.
is a
cost is an
problem.
issue.
Okay. Practical
Convincing us.
problems are there for prolonged antibiotic. That's right. The study was selected, in fact, but it was only a pilot study. It
Mission.
was an outbound unit, actually. This
Oh.
Indira Gandhi hospital is an outbound unit. I mean, it's a referral hospital. And they have taken only the outbound babies. And in fact, they have excluded all sick babies and extreme
that's true.
terms, low birth
Yeah.
weight, all seriously
Yesterday when we
sick
discussed
babies,
about
staff
this, whether
infection.
IBN and outbound, whether it was
They have
both
selected the
included, we were
OBN
discussing
ones.
yesterday.
Yeah.
And
We
now
should
for
thank
sharing
IAP
all the-
Thiruvananthapuram and
yes.
Dr. Benno, Dr. Anju, Kanmani for giving us this platform for presentation.
Yes,
Thank
Benno
you
is
so
always
much,
with us.
and
We had- I mean,
thanks
I
to
mean,
your
this is a,
motivation also to our postgraduates.
Joe sir also.
Sir, as you know, sir is actually very for supportive with IAP development. Yeah. So I would like to thank all the PG students for the wonderful presentation. Had a little bit of technical issues, that's why I had to leave. And thank you, Roy Shankar sir, Karthika ma'am, Maya ma'am, and of course Anju sir.